Chapter 13. Chapter 13 is medications. In this chapter we're going to briefly touch on the common medications administered by AEMTs. A number of these you should already be familiar with from your time as an EMT, particularly those of you that were EMTBs. You had some exposure to some things like IV maintenance, as well as things like oral glucose and aspirin and nitro and whatnot. This chapter, while short in pages and slides, has a lot of very important information in it, and much of it has to really be just continuously reviewed for the simple fact that there's not a good, easy way to make this sink in, other than if you can kind of start to put two and two together on what this drug actually does. It may help you a little bit in some of those areas. So looking at mechanism of action really is an important area to look at. As always, simply watching or listening to this lecture is no substitute for reading and studying the chapter. There's an additional piece of information you may want to have available to you while you're reviewing this. There in the course page is the AEMT medication reference or medication supplement. It's found up in the top part of the page up near the syllabus schedule and whatnot. That has a lot of good information in it. It is a kind of lengthy document. However, you do not need to print the entire thing. If you were to print, if you wanted to have it available sitting next to you as you were studying and as you were reviewing, you just printed the very first section out of that, which I think is somewhere around 13 pages or so. Sounds about correct. That will have all of the medications in it that we're really going to talk about in this. Okay, maybe it's a little longer than that, about 24 pages. So, but that has all the medications in it that we're going to be touching on. And it's really a general good reference. If you're not going to do that, you'll just need to make sure and refer back to the pages within the chapter here, pages 224 through 228, or sorry, 324 through 329, I guess, that has the medication profiles. So you'll want to refer to those on a regular basis throughout this short discussion on these medications. You are going to be responsible for all of these medications. We will expect you to have a somewhat warm grasp on some of these medications, actually all these medications, as we go forward. However, as we come to the individual emergencies that we are going to use some of these on, we'll probably revamp and rediscuss and rehash some of these medications a little bit more. We most likely will also be having some quizzes on some of your drugs as we go along, perhaps in the skill day settings. We may have some short quizzes for you. We'll let you know ahead of time before those, just to make sure you're kind of getting a formal grasp or a good grasp on giving these medications. So the objectives, obviously you can read those objectives out of your textbook. And in all reality, there's two objectives to this chapter. However, the second objective reapplies and reapplies and reapplies to each one of the medications. So, AEMTs will administer a limited number of medications to the patients. Safe medication administration is organized into a drug profile. So that's what you're going to find in your drug profile or your drug medication supplement, or on the pages as I previously mentioned here. Also, just for your information, towards or in the back of the book, Appendix 4, which starts on around 1100 or so. Let me find it. 1099. Starts on 1099 in your text. Has some additional medications. So if you're working in a paramedic level service, or you're working in an emergency room, and they're using certain drugs, you may be able to reference many of those emergency drugs back there. I can also make available, and I'll just go ahead and probably post this into the course document, the paramedic version of the drug supplement that we have. I basically took the paramedic version, pared it down for the advanced EMT, and it has a lot of drugs in there for you to take a look at. Your AEMT supplement has a lot of reference to home meds in it, but the paramedic version has not only the expanded scope drugs for the paramedic, but a lot of commonly used hospital and emergency room drugs. So I'll post that in there. I wouldn't recommend anybody printing that. If I remember right, that one's knocking on 200 pages long, so that's a fairly lengthy document. But it's good reference. It's good reference material. So, and if you haven't already started looking for a drug reference app or flip guide or book or whatever, I still really strongly suggest that you take the dive into either purchasing or finding a free one, and there are a number of free ones that you can use throughout the remainder of your practice in advanced EMS. Secondly, or thirdly, I guess on here, contact medical direction for guidance when needed. That's something I think is often forgotten about when we talk about medications, treatment protocols, and other treatment techniques in EMS, is we can always get online and talk to med control or medical direction and say, I'm not really sure where to go with this. What do you think? You know, it'd be better if you didn't do that over the radio. It'd be better if you could do it on the phone. But you know, sometimes all you got's all you got. All right, so this then will refer back to your case study in the beginning of the chapter there. So medications are part of the supplies and equipment that need to be inventoried at the beginning of each shift. So each service is going to have its own policies, procedures, so on and so forth, that pertain to how do you check and store your drugs. We talked about this, would have been in Chapter 11, how to store your medications, because a lot of them are not particularly friendly with light and air and heat and so on and so forth. So knowing what your local process, procedures, and protocols are is going to be really important. Some places they'll do a very intensive and thorough inventory every month, because drugs will have expiration dates on them that expire on a monthly basis. I want to stop and draw your attention. I want everybody to pay attention here for just a moment. There are two ways that drug expirations are listed. This is commonly screwed up, messed up information. The two ways that drug expirations occur, at least printed, are you'll either have a month and a day, a month and a year, so we'll say January of 2013 or 01/2013. They'll have that printed on the label. That means that that drug expires the last day of the month. So in this case would be January 31st of 2014 is when that drug will expire. So 01/2014 expires January 30th, 2014. I'm sorry, 31st, 2014. If the drug has a day listed in its expiration, so let's say it's 01/01/2014, that drug then expires on that day. So there's really, it either expires the first day of the month or the last day of the month, almost always. I can't ever think of a time in which I saw one that expired in the mid-month somewhere. The other thing to keep in mind with expirations is if we have multi-dose vials that we're reusing from patient to patient. I don't think there's a lot of EMS services that are doing that are carrying multi-use vials. I think they're using them one time, one and done. But if you use a multi-dose vial, it expires generally within 30 days once you open it. So once it's been pierced, once the cap's been flipped off of it, and you've pierced that rubber seal, it has a 30-day shelf life. I'm not a big fan of multi-dose vials because a lot of times we get in a hurry and people can forget about how they need to make sure and be aseptic in their multi-dose vials. So if you have used a needle and a syringe and administered something to a patient and it came in contact with their blood in any way, shape, or form, so we could say if the blood backed up in their IV and it got into the tubing and then we stuck our needle into there, we've really contaminated that. So we could potentially cross-contaminate something by using multi-dose vials. So it's not something that I recommend, but some places do still carry them. The other thing to keep in mind, and this would be more if you're working on a paramedic level service, is some of the drugs that paramedics use are refrigerated drugs, and they are good only for a limited amount of time outside of refrigeration. Most drugs, and please understand I'm saying most, not all, most drugs that are supposed to be refrigerated will last for up to 30 days outside of the refrigerator in a drug bag or a drug compartment, provided that they stay at room temperature. Understanding room temperature is roughly 72 degrees. If you have a hot garage in the summer and a cold garage in the winter, it's going to greatly shorten those shelf lives. Now, cold garage is probably better than a hot garage, but nonetheless, if it's not being stored at room temperature, it's having an effect on the medication in there. Here's a great example of how storage of your drug is so critically important. In 2005, I was on the medical staff for the National Boy Scout Jamboree in Fort A.P. Hill, Virginia. Well, if you're not familiar with this, the National Boy Scout Jamboree is a collection of about 40,000 people living in tents for about 10 days during this giant camping event. And it's a lot of fun. It's really impressive to see. But nonetheless, in 2005, the National Jamboree was the end of July, beginning of August. That's the typical time frame that they hold it. But Virginia, in the end of July, beginning of August, room temperature outside is not 72 degrees. It's somewhere about 102 degrees. It's hot. It's very hot in Virginia in the summer. So we had a whole bunch of Boy Scouts who came to camp and thought, well, I have my little igloo cooler. I'll store my insulin in it because I store it at room temperature at home, and you can do this. Some insulins are fine to be stored at room temperature for up to 30 days. Again, I can store my medication at room temperature here in my little cooler in my tent. Well, obviously, you very quickly lose all the cooling mechanisms of your cooler, and they become more of a little hot box than anything. And the scouts that were not diligent in making sure that it remained cool or bringing their medications to us at the medical center to keep in the refrigerator were quickly found to be having diabetic reactions because their insulin was no longer any good. Thankfully, in most cases, they were getting a little more on the high side of things than they were on the low side of things because when you have hyperglycemia, you generally have a longer onset, and the patient remains more conscious and alert for much longer than do the patients who have too much insulin and not enough sugar. So that's a prime example of you got to make sure you store it at the right temperature. Otherwise, you have all kinds of hell breaking loose. So knowing what your processes are is something you have to keep in mind. The service that I work for part-time, we'll do a beginning of the month, actually about 3 days before the next month starts. So we'll take, for example, say December 27th, 8th, somewhere in there. All the ambulances get gone through in depth and in detail, and all of the expiration dates are checked. Anything that's getting ready to expire is pulled and replaced. So it's just got a couple days left on its shelf life. The probability of it getting used is probably pretty minimal. So they pull the about to expire stuff and put the new stuff in, stuff that's got a longer expiration date on it. Then, after those have been gone through and replaced, everything gets sealed up with a tag. There's kind of a locking plastic tag system that the only way you can really get to it is to break the tag or break the seal. And so that tag then symbolizes, and it's a different color each month, that tag symbolizes, yes, it's been gone through and it's in theory good to go for another month. So they'll mark it with a little Sharpie marker, put their initials and their date on it, that who did it and when they did it. And so we've got some accountability there. There are a few things that still remain a daily check sort of item, and as when we're checking things like oxygen masks and blood pressure cuffs and cardiac monitors and that sort of thing, we also check to make sure that the drug pouch is sealed and the drug bag, where we have most of our drugs, which sits in a separate bag within the truck, is also sealed. So we have the pouch in the top of our jump bags or our airway bags. It has the common medications, the nitros, the D50s, some epinephrine, and a couple of the cardiac arrest drugs. So it has the more commonly used drugs in this drug pouch in our jump bag. The less commonly used drugs are in another bag that we'll grab as needed. So things you have to keep in mind, you have to know. You have to know your drug profiles. You have to know these drugs. You have to understand what they do, when not to give them, how much to give, what we're hoping to see, what we might see, and then those special considerations that go along with. Almost always, before giving a drug, we want to obtain a sample history on our patients. There's very few situations in which we're not going to get at least a full primary assessment and at least a minimum of a sample history on somebody. The two major examples that I can think of offhand would be oxygen, and hopefully we're going to get an amended sample history, get the short version, and then epinephrine for the anaphylactic patient. In most cases, we're going to speed right ahead in getting into those drugs. Now, that's not without risk, and we have to weigh that risk versus the benefit. But we should really try to obtain a full primary assessment and a sample history whenever possible prior to giving a med. We need to know what are the signs and symptoms, obviously, because in order to give the correct drug to the correct person, we need to know that, hey, they have the indication. Allergies. Every one of the drug profiles you will see lists hypersensitivity as one of the contraindications. And that hypersensitivity basically means if they have an allergy to it. So if they have an allergy to it, don't give it. Medications. We want to know what medications they're on. Are they already on this drug? Are they on a similar drug? Or are they on a drug that will have an interaction? Past medical history. They may tell us, well, I don't have any medical history, but they have a list of 6 different medications they're taking. You obviously have something if you're taking those medications. Last oral intake, probably the least important of the sample. However, that can help us determine, did this diabetic recently eat? Or is this person having an allergic reaction to something? It's really more important when we're getting ready to take them to surgery. And then the events leading up to the injury or the illness. So we'll now plow forward down into some of our medications. And we're going to start with IV solutions. There are really 3 primary IV solutions that we use in EMS. Normal saline, dextrose 5% in water, and lactated ringers, or ringers lactate, or also sometimes called Hartman's solution. And those are the 3 primary solutions used in EMS. Now we may do a little monkeying around to dilute something out, say we take some D50 and some D5W, we mix it together and make D10 or D25. That's not really technically an IV solution. You can get a D10 solution, but in most cases we don't carry that. We can make that. So IV fluids are medications. They have indications, contraindications, and side effects. In most cases, when we start IVs, we're actually starting them precautionarily simply for the fact that we may need to give this person a med. We may need to give them a drug, and so we want to have it on hand. So in all reality, many of the IVs we start, we don't actually end up using. However, occasionally we also are starting them to replace volume, whether that's from dehydration or blood loss, burns, bleeding, so on and so forth. So we're not always dumping tons and tons of fluid in them. Remember that many of our IVs, if they're even started with a bag, because we can start an IV lock. If we're starting them with a bag, we certainly can start that at what's called TKO, or to keep open. To keep open, if you remember from way back in week 1, is around 30 milliliters an hour. So that's not much at all. Okay, so when we talk about some of these solutions, we refer to them as crystalloid solution. Now, there's a difference between crystalloid and colloid. Crystalloid is a dissolved crystal in water, and a colloid is a protein base in water. Colloids actually are a much smaller package most of the time, where a crystalloid is a larger package. Colloids are expensive. They don't have good shelf life. Some of them are actually produced from human blood, so there's some possibility of transfusion issue there. But crystalloids are generally fairly safe. And to keep this straight, I remember crystalloid, normal saline is salt water, sodium chloride is table salt, dextrose is sugar, so I think of table sugar. Those are both crystals. We can dissolve them in water. There you go. That's how I keep those straight. Remember, we may have hypo, hyper, or isotonic solutions, and I believe we talked about this some time ago. A hypotonic solution is a solution that has a lower oncotic or osmotic pressure than that of blood. Hyper is a higher, and iso is equal. So with an isotonic solution, we put isotonic solution into somebody's vein, the water stays wherever we put it. It doesn't pull water, it doesn't push water. With a hypotonic solution, D5W is our example of hypotonic. Both normal saline and lactated ringers by themselves are isotonic. So when we put those into the vascular space, they stay in the vascular space for some time. They don't stay there forever, but they stay there for some time. Isotonics like D5W, those will actually push a lot of water out of the vascular space. So the vascular space doesn't get filled when we give D5W. It gives its water away to the tissues surrounding it. A hypertonic solution, and D50, dextrose 50% water, is actually hypertonic. And D50 will actually rob water. So if you give a hypertonic solution, you can give a saline, a sodium chloride solution that's 3%, not 0.3, but 3.0% sodium chloride. That is an extremely hypertonic solution, and it's going to pull water. So when you give D50 into an IV, it's going to pull water from the surrounding areas into the vessel to help dilute it and move it on. So when we're talking hypertonic, it pulls water; hypotonic, it pushes water; and isotonic, the water remains the same. So normal saline, 0.9% sodium chloride. Normal saline is the most commonly used solution that we give in EMS. It's very versatile. We can give a little bit of it and it doesn't affect the overall fluid balance. We can give a lot of it and it will help fill up some of the vascular space. So if we have a person that's bleeding or a person that's dehydrated, normal saline works. If we only started at TKO, 30 milliliters an hour, we don't have to worry about it causing fluid overload. But we have to watch it. We have to be very careful. So it's typically given for rehydration to replace the vascular volume, and then for diluting many of our medications for an IV infusion. So normal saline is probably the number one you're going to be giving. So if we want to look at normal saline, if you look at 323 in your text, or you can look at the drug profile in your medication guide regarding normal saline. Normal saline is an isotonic crystalloid, so it means the water stays the same. Is a clear liquid containing water, 154 milliequivalents per liter of sodium, approximately 154 milliequivalents per liter of chloride to match the concentration of the human body. So that's, remember, approximately what we find in the human body. It's basically salt water. So it replaces the missing electrolytes of sodium and chloride, and it has the water to replace the plasma and the volume. It will temporarily expand that vascular volume, so it goes in there and it fills up the space. Eventually it is dissolved and pulled away, but it stays there for a significant amount of time. It is indicated for the hypovolemic patient, heat exhaustion or stroke patient, and a diabetic ketoacidosis patient, as well as can be used in just TKO. It is contraindicated, should not be given to patients with heart failure because fluid overload may occur. I don't particularly care for that statement because it makes you think, well, I can't give it to a person with heart failure. You can. You can give it to just about anybody. You just have to watch how much of it you give. Do not continuously disregard your IV and just let it flow. And that's easy to do. Once we start an IV, we got it going. We maybe tried to flush it, flush the line a little bit. We had it running wide open to make sure we weren't infiltrated. And next thing you know, we forgot about it. Now that patient's received 500 mLs of fluid. If the patient has congestive heart failure, you give them 500 milliliters of fluid, there's a really, really good chance that that patient is going to now have really wet lung sounds, and you are going to have increased their difficulties. So be very, very cautious when you have IVs of isotonic solution going into your patients with, say, congestive heart failure. Precautions. Patients receiving large volumes of normal saline should be carefully monitored for fluid overload. Anytime that we are going to give a person a fluid bolus or a fluid challenge, as it sometimes is called, where we're going to give them 200, 400, 600, 1,000 mLs of fluid, we want to check their lung sounds before, we want to check their lung sounds after. And we want to make sure that as we're going along, that person doesn't start to complain of being more and more short of breath. That means we're overloading them on fluid. If a patient has lost a significant amount of electrolytes, it may be more appropriate to use lactated ringers or an alternative IV fluid for electrolyte replacement, because this only has part of what we need. This only has some of the necessary electrolytes, not all of them. So lactated ringers may be more appropriate. Side effects, large amounts can result in hemodilution and an electrolyte imbalance. So we can give them too much sodium, we can give them too much chloride. We can also dilute their blood so much, so if we gave them, this would be like if we gave them 2 or 3 or 4 or 5 liters of normal saline, we can dilute their blood so much that they actually, in a sense, become somewhat anemic. Dosage is going to depend on what's normal for that patient. What do we need for that patient? What's the protocol say? Remember, to keep open or TKO is 30 mL an hour. Most commonly, the other IV drip rates for EMS are wide open, or wide open for a short period of time while we give them a bolus. In most cases, we are not doing 125 or 150 mLs an hour. It's not common for us to do that. We need to know how to do it. Should we need to set it at that, or should we be doing an interfacility transport? But it's not very common. This is an IV infusion, and this comes in anywhere from I don't like to put how these drugs come supplied, because so often they change and each manufacturer does it so differently. So I've seen them in as small as 50 milliliter bags, or in fact you can get a 10 milliliter vial of it if you really wish. But a 50 milliliter bag up to a 3,000 milliliter bag. Most of the time it's 250, 500, or 1,000. And you use that obviously with a drip set. So that's normal saline. Dextrose 5%, D5W. This has the benefit of giving them a little bit of water with some carbohydrate or some sugar in it. D5W is no longer really the standard for most systems and services as being your medical IV. 20 years ago, 25 years ago, D5W, you started D5 on your medical patients, you started normal saline or lactated on your trauma patients, or your dehydrated patient. That kind of went away, because when we used to say we were going to start D5W with a 60 drop set and a 20 gauge catheter, and then next thing you know, we've got patients who are taking a dive on us and they need a fluid bolus. So maybe that patient who was starting to complain of abdominal pain, which sounds like that, well, that's a medical patient. And now all of a sudden, ooh, I felt something pop in my belly, and now my blood pressure is 20 over crap, and my heart rate's 150. That person, if we try to give this person a fluid bolus of 500 cc's of D5W through our 60 drop set, we're going to be there all day doing that, and that person's going to die. So that's the reason why things have basically changed, and they've said start everybody on a macro drop set, so 10, 15, or 20. Start everybody on normal saline, run it at TKO, and when necessary to give a medication, or if we really know we need to give this person sugar, then we'll use D5W instead. And if we're doing a medication, then we'll consider doing a micro drip set if we're going to do an infusion. So it is okay to use this as a TKO IV in patients that are prone to fluid overload, because they're going to lose that water out of the vascular space pretty quickly. But again, not usually the standard. This is a hypotonic carbohydrate containing solution. It is sterile water with 5% dextrose, or 5 grams per 100 mLs. The mechanism of action, D5 combines dextrose and water in a hypotonic concentration that will not remain in the vascular space, and it reduces the fluid overload possibilities. It is used in prophylactic IV access, so basically TKO or just in case, and is used to dilute concentration or concentrated drugs for IV infusion. It is also used for the replacement of dextrose or sugar. Should not be used for patients who require IV fluid replacement or in patients that are hyperglycemic. Do not use in the traumatic brain injury or stroke patient. Free sugar getting into the brain tissue by spilling out of a vessel can be dangerous. It can actually start to kill off brain cells. So it's something we have to be cautious with. The hyperglycemic patient, I'll be real honest with you, if you start D5W on a patient who's hyperglycemic and you give them 100, 200, 300 cc's of D5W, the amount of sugar you gave them is not going to make a difference. It is not going to be significant enough that it's going to kill them. But if you strongly suspect they're hyperglycemic and you do the assessment and find out that they are, don't start it. They don't need it. Oops, back up. Side effects. Side effects. Pretty rare when given at therapeutic doses. Occasionally you could cause them to become hyperglycemic, or you could cause them to have some brain issues, but not much to be worried about. Interactions. It's not to be used with blood or blood products. Normal saline is the only IV solution that is safe to mix with blood products. You're not going to have to worry about that in case you're with a paramedic in there. talking about blood. Usually given TKO. Now it may be given in a different rate via the hospital in the doctor's order, but it's an IV infusion, most commonly given in either 100, 250, or 500 ml bags. They also come in 50 milliliter bags for diluting drugs. And lactated ringers. This is also sometimes called Ringer's lactate, or also sometimes called Hartmann's solution. There's a couple of ways that it's referred to. It is most commonly given for the patient that's acidotic, so they have hypovolemic shock or they're in DKA. And it's also given for patients with hypokalemia, which means low potassium, low blood potassium. It is an isotonic crystalloid. It is a sterile water containing sodium, 130 milliquivs per liter, potassium, 4 milliquivs per liter, calcium, 30 milliquivs per liter, chloride, 109 milliquivs per liter, and lactate, 28 milliquivs per liter. So this has additional electrolytes that the body needs, and it really makes it kind of an optimal solution for that patient that is dehydrated and starting to become hypovolemic. That mechanism, again, it is a fluid replacement and electrolyte replacement. It is indicated the best patients for this are the hypovolemic shock, DKA, and the burn patient. Burn patients get a lot of fluid shifts and will have a lot of electrolyte imbalances. It is contraindicated in the patient with heart failure, renal failure, or suspected hyperkalemia. So if you have a strong reason to believe that their potassium is very high, this is not a good solution for them. Potassium is one of those things that can be very dangerous very quickly and not something you want to let run out of control. In many cases, potassium overdoses are fatal. Precautions, basically monitoring closely for signs of circulatory overload, just as we did with the normal saline. Rarely any side effects. It is not intended for use with blood. The dose, again, is going to be based off of your protocol. TKO is 30 mils per hour. It is an IV infusion, and LR is most commonly supplied in 500 and 1,000 ml bags. So, study and know the key information on those three solutions. All right, so the type of IV that we're going to select is really going to depend on our patient's condition. And in many cases, normal saline, which is 0.9% sodium chloride, is what we're going to use in the pre-hospital setting. Not all services carry all of these solutions. Most services will carry the normal saline, and they may carry some small bags of D5W for mixing their drugs in. There are many places that don't carry lactated ringers anymore. Lactated ringers and D5W used to be the fluids of choice, but since that time, normal saline has kind of taken over as the most prevalent. All right, so to move on to some of the other medications, we'll talk albuterol. Albuterol sulfate is a bronchodilator drug intended for people with respiratory distress, primarily asthma and COPD. However, there are other times in which we may give this. So let's look at this a little bit. Now, I'll take a moment. You can look in 324, first column towards the bottom there. It has in the field, and it talks about levalbuterol, which is also called Xopenex. That's another example of a bronchodilator drug. The scope of practice talks about giving an inhaled bronchodilator, and that could be albuterol, which it is in most cases, could be levalbuterol or Xopenex, could be even another one like, it's left me right now. So there are a few other bronchodilator agents that could potentially be used, and it's going to be based off of your protocol. If you remember, I talked in the previous chapter about Duoneb. Duoneb doesn't fit this perfectly because Duoneb is a bronchodilator and an anticholinergic drug. So it actually exceeds the scope of practice of an AEMT. So albuterol is a beta-2 selective sympathomimetic bronchodilator. Wow, what does that mean? Well, remember when we talked about the pharmacology, we talked about pathophysiology, we talked about alphas and betas, and beta-2, we had 2 lungs, 1 heart, so beta-2 has to do with the lungs, and it is a selective sympathomimetic. The sympathetic nervous system is fight or flight, and it causes dilation in many cases, causes you to be revved up, and so if this mimics the sympathetic nervous system, it's going to be like kicking in your own fight or flight, and so that sympathetic mimic then causes dilation, causes an increase in the heart rate. Now, because this is primarily beta-2, it deals mostly with the lungs. So we have mostly bronchodilation going on, and that's what we're looking for. Albuterol sulfate, for some of the trade names or brand names for that being Proventil or Ventolin, is a sympathetic beta agonist. Remember, agonists are pro, antagonists are against. Used to reverse the bronchial muscle constriction in patients with asthma and COPD. It can be used in other patients, so such as sometimes it gets used in patients who have been exposed to toxic inhalations, burns, that sort of thing to their respiratory tract. Could also be used in some kids, say in like epiglottitis or croup. The mechanism of action acts on the beta-2 sympathetic receptors in the bronchial smooth muscle and causes bronchodilation. It is indicated generally for people who have wheezing. Wheezing gives us the indication that they have bronchial constriction. Rales and rhonchi, that usually means that they have fluid, and this isn't going to help a lot with fluid. Occasionally, physicians will order it, though, for the CHF patient or other patients who need some improvement in their respiratory drive. Now, for us, we're going to really be based off of protocol. There are negative side effects that go along with this that we'll hit here in just a second. So that patient with congestive heart failure, you may have to weigh the risks versus the benefits of giving this med. It is contraindicated in those that are hypersensitive and those who have symptomatic tachycardia. So if you have a patient who's complaining of some chest discomfort and their heart rate's 120, 130, and they maybe have some wheezes, you may have to think about this and say, what is the best benefit versus risk here? And it might be something you make a phone call to medical control on, simply for the fact that if this person already has a heart rate of 130, let's skip down to side effects there. The side effects that commonly come with this are anxiety, palpitations, which is a fluttery feeling in your chest discomfort, headache, perspiration, and tachycardia should be in there as well. So if they're already tachycardic and we make them more tachycardic, could we cause them to have some significant cardiac event? Certainly could. All right, so albuterol has minimal beta-1 adrenergic effects, but may increase the heart rate and the myocardial oxygen demand. So we have to be cautious on that patient with heart disease. So I really suggest that we don't just instantly slap people on albuterol who are complaining of shortness of breath until we've done some reassessment and reevaluation of our patient. Interactions, other beta agonists should not be administered concurrently with albuterol. So we don't want to give other pro-beta drugs with albuterol. This also brings up an another interesting topic. There's a certain classification of drugs that are called beta blockers, the OLOL drugs, metoprolol, which is low pressor. Those drugs block the effects of beta, and it is possible that they're going to block some of the effects of your albuterol. So you need to be cautious there. Keep that in mind. The dosage, you're either going to give this in a meter dose inhaler, and it's generally 1 or 2 90 microgram sprays. It's a meter dose inhaler. You don't have to do any measuring. You just have to squeeze it. If you have a spacer device, use a spacer device. Spacer devices are great. They're usually called aero chambers. That's a brand name. I like the brand name because the brand name is my last name. I wish it was my family, but it's not. The spacer device helps hold that so it doesn't get away. So if they need to take 2 or 3 hits off of it, they can still get all of the medication, as opposed to letting a lot of it get wasted. Otherwise, we're going to give a small volume nebulizer, and this says 2.5 milligrams diluted in 2.5 mLs over 5 to 15 minutes. Pediatric dose of 0.15 milligram per kilogram diluted in 2.5 mils of normal saline. Let me give you the realistic version of this. Most of the time this comes prepackaged, and when it comes prepackaged, it is actually in 3 milliliters. Well, that's the total volume of the drug, because you're going to have somewhere around 5 mLs of the albuterol. You add that to the 2.5 of normal saline, it ends up being about 3 mLs. So 2.5 milligrams is really what we're shooting for. 5 to 15 minutes. It usually takes right around 8 minutes to give breathing treatment at around 8 liters. And then pediatric patients, in most cases, we just give them half of what we would give an adult. Officially, it's 0.15 milligram per kilogram, but usually we don't have a good way to measure that. It is inhaled. There is an albuterol syrup that some pediatric patients will receive as like a cough syrup, but we don't give that in EMS. And then again, it's either packaged in a meter dose inhaler or in a nebule. Aspirin, acetylsalicylic acid. This is used in the treatment of acute myocardial infarction. What it does is it inhibits the platelet aggregation to reduce the additional blood clotting. So it takes some of the sticky off of the platelets so they don't stick together quite as well. It doesn't break up a clot. It just keeps the clot from getting bigger. It is a good drug. Luckily, it's been around for a long time, because if they found it today, it would be a couple dollars a pill. Right now, we can buy a whole bottle for $1. So, the class of it is a platelet aggregation inhibitor, and it is a non-steroidal anti-inflammatory drug. So, it is a platelet aggregator inhibitor, an NSAID, and an analgesic. So it has a lot of actually great benefits. It fights fever, it helps reduce pain, and it reduces platelet aggregation. So, and it fights inflammation. So the abbreviation for this, if you see in your textbook on 324, is ASA, capital A, capital S, capital A, ASA, ASA. That's the common abbreviation for aspirin. Some brand names of this would be Bayer, Bufferin. Those are some of the more common brand names. The description of it, aspirin is a salicylate, and that reduces platelet aggregation by inhibiting the release of prostaglandin called thromboxane A2. Probably not ultimately important. Just remember that it inhibits the platelet aggregation. Aspirin blocks part of the chemical reaction responsible for activating the platelets. And in a pre-hospital setting, we usually give this for acute coronary syndrome. You may give it for certain strokes. However, patients with bleeding or hemorrhagic strokes, they are not going to benefit from getting this drug. It has the potential for it to be kind of a negative side effect. We're not absolutely positively forbidden from giving aspirin to people who are sick. I've got flu-like symptoms. But we would need to have a protocol that will allow us to do that. So in most cases, the treatment with aspirin we give is for our acute coronary syndrome patients. Contraindication. This is one of the top drugs that has an allergy to it. A lot of people are allergic to aspirin. So hypersensitivity. We generally do not give it to children or minors with a suspected viral illness or potentially the flu-like symptoms, simply for the fact that there's a disease called Rye syndrome that can hit some of these patients, and it's very, very ugly when this disease hits them, or when this syndrome hits them. Precautions, you've got to be very cautious in the patient who has asthma and seasonal allergies. Sometimes they do not react well to aspirin. It can actually set off their asthma. So use cautiously in the patient with asthma. Also, stomach ulcers, because it'll continue to make them bleed. Liver disease, because that's where it's processed and it's kind of a tough drug to process. Alcohol abuse, they're more likely to be a bleeder and have liver disease as well. Kidney disease and coagulopathy. So if they already have problems with blood clotting, we don't need to make their blood clotting even worse. Side effects, GI upset. It does tend to upset their stomach a little bit. It is an acid. Bleeding, nausea, vomiting, and wheezing. The interactions, a few of the interactions are actually seen in the pre-hospital setting. It's really a relatively safe drug when we're talking about giving it with other meds. The dose, Heart Association recommends 160 to 325. That's just the basic recommendation. Children's aspirin is preferred because they can chew it, which increases the rate of absorption and doesn't require water to swallow. We don't carry a lot of drinking water in our ambulances, so using a chewable aspirin is the easiest thing for us to do. Your protocol will vary. Your protocol may be as low as 81 milligrams and maybe as high as that 325 for most patients. You can go with a higher dose of that. You can actually go to like a 650 milligrams, but you're looking really more for the anti-inflammatory properties there than you are the platelet aggregation properties. It is given orally, and they usually will chew up their 81 milligram tablets. 50% dextrose solution. This is a sugar in water solution. It's given for patients with a decreased level of responsiveness who cannot receive an oral source of sugar. This is a hypertonic solution. It is extremely high concentration, and if you get it outside the vein, it can be very, very ugly and can cause some significant tissue damage. So be very, very careful when you're giving D50, that you're giving it through a good free-flowing IV. It is a carbohydrate, very high concentration, 50 grams in 100 mLs, or in most of the pre-filled syringes you'll get, there'll be 25 grams in 50 mLs. It's given to increase the glucose concentration in those hypoglycemic patients. It is intended for hypoglycemic patients. It is contraindicated if we believe they're bleeding into their brain. Again, that high concentration of sugar can cause a lot of tissue damage up there. It's also contraindicated in hyperglycemia simply for the fact that they don't need any more sugar. The probability of us causing a lot of issues for that person by giving them extra sugar if they're already high is pretty slim. However, it's just going to make it harder for us to get them corrected. Precautions, check the blood glucose prior to giving it. Now, it used to be if they had an altered mental status, we pretty readily gave D50 as part of something called the coma cocktail. That was another day in EMS. That was the days of if this, do this, don't ask any questions, carry on. Well, now we're thinkers in EMS. We've gotten away from that whole cookbook medicine because, to be frank, it's stupid. So we're smart enough people to make these decisions that this person doesn't look like they're hypoglycemic. So let's keep looking. Let's check their blood sugar. Oh, well, their sugar is fine. They don't need this. Side effect, it can irritate veins. It can cause you to have to blow an IV. So be very, very careful with it. Watch very closely as you're doing this. Pay attention. There's really no significant interactions. Anytime you give a drug through an IV, make sure and flush that IV out really well. If you flush the IV out well, in most cases you don't have to worry much about interactions with the next drug you give through it. The dosage is generally 25 grams slow IV push. The reason that it's slow mainly because we need it to dilute as it goes in, and it's so thick it's just hard for us to push anyway. You can repeat it in about 10 to 15 minutes if their blood sugar remains below 70. The pediatric dose is half a gram per kilogram of a 25% solution for basically school-aged kids. Most adolescents will probably just kind of give the D50 to. If they're very, very small, if they're an infant or a neonate, we can give them a 10% solution, and we'll give them that same half a gram per kilogram, just more diluted. So if we need to make D25 out of D50, we drop equal amounts of water or saline into a syringe as we do the same amount of D50. So for example, we could put 10 milliliters of D50 into a syringe and then fill it up with 10 more cc's or milliliters of normal saline or sterile water, and that will give us a 50% of the 50% solution, which then is 25%, so it's half strength. If we needed to make D10, then what we simply need to do is draw up, say, 2 cc's of D50, and then we would draw up 8 cc's of of water or saline, and that would give us D10. So the route is given slow IV push. Most of these drugs that are listed as IV drugs can also be given IO, this one included. You would want to probably dilute it if you were going to do this one IO. Monitor your IV site. And then usually this comes in a 50 cc syringe with 25 grams of sugar in it. Epinephrine 1 to 1,000. Epinephrine 1 to 1,000 is a sympathomimetic. It is a bronchodilator. It has a lot of really good properties when we're giving this to somebody who's acutely ill. For people who are not acutely ill, though, it can be a very dangerous and ugly drug. We have 2 concentrations of epinephrine, 1 to 10,000, which we give to cardiac arrest, or if we had a patient who was hypotensive and they needed epi for their asthma attack, which 1 to 10, that's 1 gram in 10,000 mLs. Or 1 to 1,000, which is 1 gram in 1,000 mL, so it's much more concentrated. That's the one that's given sub-Q or IM for those patients that are having bronchospasm. Advanced EMTs generally give the 1 to 1,000 either through an auto-injector, like an EpiPen, or giving it sub-Q or IM via needle and syringe injection. It's a naturally occurring hormone. It's one of your catecholamines in your body, secreted by your adrenal glands in response to a sympathetic nervous stimulation. Epi binds to the alpha-1, beta-1, and beta-2 adrenergic receptors. It causes vasoconstriction, an increase in heart rate, and force of contraction, and it causes bronchial smooth muscle relaxation. So in our patient who has an anaphylaxis where they have very dilated peripheral vessels that are leaking, getting some of that vasoconstriction will be very beneficial, and then getting their smooth muscles of their bronchioles to relax and open up will help them with the breathing aspect. So Epi 1 to 1,000 is administered to anaphylaxis, occasionally to some other patients like a status asthmaticus or patient with severe COPD. or a toxic inhalation occasionally. And it helps just open them up, get more air moving in and out. Used very cautiously in patients with a significant cardiovascular disease or hypertension, because this is going to really wreak some havoc on their heart. Epi is inactivated by exposure to sunlight or when given with an alkaline solution, because epi causes a very strong sympathetic stimulus. Patients can experience chest pain, palpitations, anxiety, nausea, headache. We're going to want to monitor that patient's vital signs very closely. So don't let your epi sit around in the sunlight. And then side effects: palpitations, tachycardia, anxiety, headache, dizziness, nausea, vomiting, all very, very common. And in those patients with underlying cardiac disease, they may also have the chest pain, and it can precipitate an AMI, and this person can start to have a heart attack. Epi doesn't really get along with very many other people. It's best if you're going to give epi, give it in an IV all by itself. Flush it really, really well. If you're going to give it sub-Q, you don't have to worry much about interactions as far as concomitant use in a line. However, some patients taking antidepressants will have an intensified reaction to their epi. The general dose for the adult, 0.3 to 0.5 milligrams sub-Q or IM. Give this every 10 to 15 minutes as needed. Pediatric dose is 0.01 milligram per kilogram. Remember, the max dose of this in cardiac arrest patients is a milligram. So this is a very, very small dose drug. So it's one you're going to have to do med math on. You can give it sub-Q or IM, and you usually will get this in either a 1 ml, 1 milligram per milliliter amp. You may get it in a vial that can be anywhere from 1 to 30 milligrams. And you also obviously can get it in the epi auto injectors. Glucagon and glucose. Glucagon is another naturally occurring hormone. When it is excreted by our pancreas, it goes to the liver, pulls out the stored glycogen, which is basically glucose storage, and breaks it down, causes it to become a usable form of glucose, and then obviously deposits it into the system. The intramuscular glucagon is typically given for that patient with severe hypoglycemia and we are unable to get an IV. Sometimes the patients are that violent, I should say violent, but they're that out of control when it comes to their mental faculties being gone, that we do sometimes have to almost fight the patient to treat them. If the patient has an inadequate liver glycogen storage, such as those that have liver disease, they may not respond. So they just don't have the glycogen to take out of there. This is a hormone with anti-hypoglycemic properties. Glucagon is a pancreatic hormone that affects that blood glucose. It promotes glycogenolysis, so pulling out the glycogen, breaking it apart, and then creating new sugar through the process called gluconeogenesis, and it will inhibit glycogenesis. So it makes it so we don't store more, we use it. The mechanism of action causes that release of the glycogen and the conversion into a usable sugar. It is indicated in the hypoglycemic patient who we cannot get an IV access on. This should not be your first-line drug in treating hypoglycemic patients. It is not nearly as efficient of a drug, and we don't see nearly the effects that we do when we can actually give them glucose. This is basically a last ditch. So don't be thinking we're going to give them both glucagon and D50 and oral glucose. It's contraindicated simply if they're hypersensitive to it. Precautions: glucagon will not be effective if the patient already has depleted their glycogen stores. So if this patient is frequently hypoglycemic and thin as a rail, they probably don't have any to use. very uncommon to have any side effects. Occasionally hypotension, dizziness, headache, nausea, or vomiting can occur. It does actually have a little bit of a smooth muscle relaxant property to it, and that's where you can get some of those other side effects from. It has very few interactions. It's 1 milligram or 1 unit. They just so happen to be equivalent. A unit and a milligram are the same when it comes to glucagon. It's not the case in all drugs. It is given IM. It can also be given sub-Q, but IM is best. That's the easiest way for it to be absorbed. Glucagon comes in a kit. It has to be reconstituted. This is the drug that has a little bit of powder and a little bit of liquid, and we have to put them together, mix it up, and then draw it back up and give it. Glucose, oral glucose. Remember, this might be in a tube. This might be in the form of a candy bar. But glucose is a obviously key carbohydrate for us to use for life and to create energy. It's a simple carbohydrate. It can be absorbed across the buccal mucosa, which means your cheeks, or through the gastrointestinal tract. So rubbing a little bit on the inside of the cheek can be a good thing. It increases the blood glucose level. It is indicated in acute hypoglycemia where the patient can protect their own airway. So we do not have that unconscious patient laying on their back and we take 15 cc's of glucose, 30 cc's of glucose, and squirt it in their mouth and hope that they can just chow it down. Because then they suck it under their lung and they get a pneumonia or they die. If they're unable to maintain their own patent airway, do not use this. Precautions: carefully monitor that patient for aspiration. That may cause them to have a little nausea or vomiting. Interactions: there are really none. The dose is generally 15 grams by mouth or applied to the buccal mucosa. You can take a tongue depressor or a bite stick and rub a little on the inside of their cheek. Usually we're going to give them the whole tube is usually what they end up getting. And it comes supplied in several different ways. So, but yeah, this is one that you should be familiar with from your EMT class. There are alternatives to this. Remember, this is just a nice, easily packaged, that doesn't expire very quickly form of sugar. There's some places that they don't carry oral glucose. They went and bought tubes of decorator frosting or icing for cakes, and basically that's the same stuff. It's just sugar. Naloxone, brand name of this being Narcan. The brand name for glucagon is usually glucagen, so it's pretty easy. And glucose can be glucose, instaglucose. There's lots of different brands for that. You can buy that one over the counter in the pharmacy. Naloxone or Narcan, this is a narcotic antagonist. And it's used to reverse respiratory depression associated with narcotic overdose. It is not used to completely knock out their high, because if you take away their high, you're going to end up with a very angry patient that you probably don't want to have to deal with. But the way that you should basically use this drug is you do what we call titrated. You give them a little bit at a time until their respirations come up. It's okay if they still remain somewhat groggy or partially unresponsive, because we don't want them to be, number one, we don't want them to go into withdrawal, and two, we don't really want them to be angry, so it's a safety issue. It has a very short half-life on it, so we may have to give repeated doses of this over time. A lot of times the narcotics will actually last longer than the Narcan. There are alternative drugs that can be given in the hospital that have longer half-lives on them, but so it should not be used indiscriminately. We should not be just running around hitting everybody with Narcan. We should not be giving them the full 2 milligrams every time. We give them enough to bring them up, maintain their respirations, and then that's where we keep them. So again, used to reverse respiratory depression associated with narcotic overdose. Narcan has a higher affinity to narcotic receptors than most narcotics do, so it will actually get in there, kick narcotics out, and take its space. So it's competitive. Naloxone is indicated to reverse the respiratory depression of the narcotic opioid overdose. Don't use narcotic as in a street term narcotic. Use it in the medical term narcotic. A lot of times we'll talk about narcotics in a street term as any illegal drug. However, narcotics in medicine are opioids. So morphine, toluene, Dilaudid, codeines, fentanyl, so on and so forth, heroin. The only really contraindication to it is known hypersensitivity. Got to be very careful when we're giving it. Rapid administration of large doses will cause withdrawal in narcotic addicted patients, and you should titrate this slowly towards getting their breathing. The other key, the two key signs that you usually use here to say, is this person potentially a narcotic overdose, is typically it's respiratory depression and pinpoint pupils. Now we'll come to this again when we get to that emergency. But side effects, very rare, occasionally hypotension or hypertension, nausea, vomiting, or some cardiac dysrhythmias. It's probably from other things, but interactions can cause withdrawal with that narcotic addicted patient. Dosage is actually 0.4 to 2 milligrams. We can give a maximum of 10 milligrams of this drug. Try to give no more than 2 at a time, and in most cases you should be closer to 1. So if you have no effect, repeat again in about 5 minutes. You can also give this intranasally, and it's the same dose. However, when we squirt it up their nose, which is not yet fully approved for AEMT use, but we'll talk about it because I anticipate that it will be. When given intranasally, they put a little cone on the end of the syringe, and it turns it into a very, very fine mist that gets shot up their nose, and it's almost as effective as IV. So it can be given IV, IM, sub-Q, intranasal, IO. I imagine it would work if you administered it via the rectum, although I don't know that many would want to do that. I'm not sure. I don't know that orally it would be the best because it might be broken down too much. You could probably also put it in a nebulizer. And it's also a drug we can put down. Paramedics will put some drugs down the ET tube, and it works that way as well. And this comes in syringes, amps, and vials. Nitroglycerin, sublingual nitro tablet or spray, used to treat patients with acute coronary syndrome, basically most of our chest pain patients. It is a smooth muscle relaxant, so it's going to smooth, or it's going to relax and dilate the coronary arteries. Also dilates other arteries, so we've got to be kind of cautious there. Nitrates can cause a significant drop in blood pressure. So if their blood pressure is already below 100 or below 90, depending on what your protocol is, you will not want to be giving nitroglycerin. Also, if you give it to a patient who has a blood pressure of, say, 160 over 84, and you take your next blood pressure and now their blood pressure is 104 over 50, you might want to think twice about giving them a second dose of that, because if it dropped it that far with one dose, if you give them a second dose, you could very easily drop their blood pressure down to a critically low point. It's classed as a vasodilator and a nitrate. It is either given in tablets or a metered dose spray for sublingual administration. There are oral versions of it. The oral versions are long-term release, so they're not used in emergent settings. It does also come in a paste or a patch. However, those take longer to take effect as well, so that's why we use the sublingual version. And paramedics will sometimes also give it in IV. There's a different IV version of it. So it decreases the cardiac workload by expanding those coronary arteries, allows the heart to get more blood, and it reduces the preload by dropping the blood pressure down a little bit so the heart doesn't have to work quite as hard. The chest pain associated with acute coronary syndromes is when we give it. It is contraindicated in hypotension, increased intracranial pressure because it's going to cause more intracranial pressure, and the use of erectile dysfunction medications within 24, and I want you to extend that out to 72 hours. There are now some really long-acting erectile dysfunction drugs that will stay in your system for up to 3 days. So if they've, it's going to be a funny, uncomfortable conversation, but you're going to need to find out if they're taking any of those. Cialis, Levitra, Viagra. Precautions: nitro deteriorates rapidly when exposed to light, air, or heat, so keep it stored appropriately. Monitor their blood pressure very closely. Discontinue it or do not give additional doses if their systolic is below a 90 or 100, depending on your protocol. It is a very potent vasodilator. Often causes headaches, may cause a little burning under the tongue, dizziness, weakness, tachycardia, hypotension, dry mouth, nausea, vomiting. Interacts. It can be accentuated by alcohol use and erectile dysfunctions and beta blockers. All of these can cause excessive vasodilation. And the dose of this is 0.4 milligrams sublingually. If the chest pain persists and the systolic blood pressure remains at least 90 or 100, you can repeat this up to the max of 3 doses, generally every 3 to 5 minutes apart. I would go on the 5-minute scale as opposed to the 3-minute scale. You don't need to get, within about 6-minute time period, 3 doses in there. You're, on the top side of things, you would be talking 10 minutes. On the bottom side, we're talking 6 minutes. You have a lot of nitro in their system at once. It's given sublingually and either in a calibrated spray or a small tablet. If you're going to give, if you have the spray version of nitro, I recommend that if it hasn't been used very, very recently, take the cap off, aim it away like into your garbage can, and give a squirt into the garbage can just to kind of reprime that pump before you give them a spray under the tongue. Don't handle this drug. Do not spray yourself with the drug. Do not handle the tablets without gloves on, because you can't absorb this. Nitrous oxide or nitronox. This is the anesthetic or the analgesic that AEMTs use in Iowa. In Nebraska, AEMTs are allowed to give morphine. Nitrous oxide is not very commonly used in the EMS setting. It's coming back, but right now it is not widespread. This is basically 2 pressurized gases, one oxygen and the other nitrous oxide. They're mixed together in a 50% mix, so 50-50. Some systems use either something called Entonox. Entonox is a single-use cylinder where they've already mixed 50% oxygen and 50% nitrous together. Some of them have the scavenger system that basically merges your oxygen source with your nitrous source. This is basically used as a modified demand valve, so that patient self-administers by holding the mask and then inhaling. So when they are holding the mask, it's not strapped on their head. There's no strap on this. It's basically a little mouthpiece or a mask with no strap on it. They hold it up to their face, and as they start to get drowsy, they'll drop it. Well, that's when they've had too much. It is a CNS depressant, and it's indicated for severe musculoskeletal pain, chest pain associated with acute coronary syndrome that is not relieved by nitroglycerin. It is contraindicated in the patient with a decreased level of responsiveness. They're unable to follow instructions. They have a traumatic brain injury. They have COPD, pneumothorax, abdominal pain, and suspected abdominal or bowel obstruction. The precautions: use only in well-ventilated areas. You can actually start to suffer some of those effects of secondhand nitrous, and it will start to make you feel a little goofy. It is a teratogenic agent, so providers or patients that are pregnant really should not be getting nitrous oxide. So pregnancy should also be placed in your contraindications. Side effects: dizziness, decreased mental status, hallucinations, nausea, and vomiting. Some of that's obvious, pretty obvious. Do not use it in the patient with sedative hypnotic medications, narcotics, or alcohol on board because it can cause excessive decreased mental status. It is used by inhalation and in a self-administered 50-50, 50% nitrous oxide, 50% oxygen, and depending on how your system gets it, that's going to be how it's supplied. I would give you a moment, take a moment to caution you. Nitrous oxide, you need to be very familiar that it is nitrous oxide, not nitric oxide. That's a completely different medication. Unfortunately, they sound very, very similar. You're probably not going to run into any nitric oxide unless you're working in a critical care setting, but it is a different drug. Oxygen, probably the one we need to spend the least amount of time on, however it's the one we give the most common. So it is an atmospheric gas. It is colorless, odorless, and tasteless. People say it smells funny. It's the mask that they're talking about, not the oxygen. Oxygen is necessary for our cellular energy production, and when inhaled, those oxygen molecules will cross the respiratory membrane, touch the hemoglobin, and then be transported to the tissues. It is indicated for patients who are hypoxic and or have a oxygen saturation less than 95%. Generally, anymore 94% or higher, we probably don't need to do oxygen. If you do, no more than 1 liter or 2 by cannula. If we give too much oxygen, it actually causes vasoconstriction and can cause us to become somewhat cellularly hypoxic. There are really no absolute contraindications to the use of oxygen. However, there are a couple times in which we have some concerns. If we have too much oxygen for patients that are either neonates that have no problems, they're doing just fine, we don't want to give them oxygen, it actually can cause some problems with their eyes, and cause some blindnesses. Patients who have COPD, if they are on high flow oxygen for long periods of time, and when I say long periods of time, we're talking hours to days, we can actually cause them to have a decreased respiratory drive because it knocks out their primary drive to breathe. However, there are no documented cases of that ever happening in the field. So if the patient is hypoxic, you give them oxygen. Don't worry about it that they're a COPD patient. They can stabilize them in the hospital and wean them back to a cannula if necessary. Yes, you may get a nurse who gets her panties in a wad because, oh my God, you gave that patient a non-rebreather and they have COPD, you're going to cause them to stop breathing. Well, I've gone round and round with many nurses on this, and there are no cases in which this has happened in just a very short term. This is somebody who's laying in a hospital bed on the medical unit for hours and days on high flow O2 that this becomes an issue. The other major issue with oxygen, obviously anybody who has recently been burning, oxygen and fire don't tend to go well together because oxygen makes fire burn better. It won't explode. Both oxygen and nitrous oxide come as a compressed gas in a cylinder, so if you're not careful with the cylinder, it can become broken. You can break the neck off of it and make it become a rocket. And then there's a really odd case of a certain pesticide called paraquat that gets used very, very rarely, but paraquat poisoning with in the presence of oxygen can actually cause the patient to catch on fire. So weird, but cool. The precautions basically goes over and talks about everything I just talked about there. Do not leave oxygen bottles standing on their bottom. Put them in a protective guard, put them in some sort of a stand, put them laying down. Do not leave an oxygen bottle standing up, even on the floor. So, not to mention the regulators you put on those things. They're easily broken and they're not cheap. They're 100, 150, 200 bucks a piece. So they're not cheap. It is a vasoactive drug that in high doses causes vasoconstriction. So the cerebral arteries and the coronary arteries can actually start to constrict when we want to get more oxygen to where we need it. So if they aren't complaining of severe shortness of breath and their saturations are in the mid to high 90s, we probably don't really need to go much with oxygen. There are very few side effects to using oxygen. It can be very drying. However, this takes hours to days again where it will start to dry out your mucous membrane. So sometimes they'll end up on a humidifier where they'll actually bubble the oxygen through some sterile water to just kind of moisten their mucous membranes. There's really not many interactions. The paraquat, like I talked about, and flame. The dose is really we're aiming towards an SpO2 of 94, 95% or higher. High concentrations of O2 over a long period of time can cause that oxygen toxicity. And a lot of times patients are kept on the very lowest amount of oxygen that will maintain what their saturations. And oxygen is going to be administered via a variety of different types of masks: nasal cannulas, Venturi masks, bag valve masks, simple masks, Drake masks, so on and so forth. And then remember, it comes supplied in a compressed gas cylinder. All right, now we'll move to a few of the over-the-counter drugs. Activated charcoal. This really has fallen out of favor in the EMS setting. Not commonly given anymore. I really don't believe that it actually fits scope of practice in Iowa or Nebraska for use, although I think that it's loosely defined, so there's the potential that your medical director would still, for some reason, want you to carry it. It is an absorbent, so anybody who knows you can put a briquette of charcoal into your fridge and it will help absorb some of those odors. It's the same reason. Or if you're in the aquarium hobby, you use activated charcoal to filter out some of the toxins. So it is a finely powdered charcoal mixed in water. Usually there's also a flavorant that's added to it. It binds with those toxins that are in the GI tract. It prevents the body from absorbing them because it binds to the charcoal, which doesn't cross any membranes, and it gets expelled with the fecal. It is given orally for the ingestion of some toxins. Things like acids, strong bases, alcohols won't work with activated charcoal. So if they have a decreased level of consciousness and they're not going to be able to fully drink down the charcoal, don't give it to them. Corrosives, caustics, and petroleum products won't work with activated charcoal. However, it will also inactivate other medications. So if we've given them a couple of oral medications and then we give them activated charcoal, it deactivates it. So side effects would be black tarry stools and constipation. There's really no interactions other than it might kill off your drug that your drugs you're trying to give them. And the dose is generally 1 gram per kilogram orally for adults or peds. And this comes in a slurry of 50 grams and 250 ml. So we're going to have to drink a ton of this stuff. So up to 500 mLs in many cases. So and they're not going to be really. It doesn't taste good, even though they put some flavorant into it. And people who can see it really don't want to drink it because it is black. It's gritty. So they do sometimes suggest, number one, mix it in a little bit of soda if you can, like Sprite. Or some juice, and put it in a cup with a lid and a non-clear straw. Might make it a little easier for them to take. Acetaminophen or Tylenol. This is a non-prescription analgesic and antipyretic. It is a fever reducer. A lot of systems don't carry it. Antipyretic means fever reducer. It is a non-prescription medication for the relief of moderate to mild pain. Not fully understood what the mechanisms are on it, but it tends to increase the pain threshold by blocking some of the prostaglandin synthesis. Given for mild to moderate pain, contraindicated in hypersensitivity. It is hepatotoxic in high doses, so this will destroy your liver if you overdose on this. People who think, oh, I'm going to kill myself, I'm going to take a handful of Tylenol, or I'm going to take a bottle full of Tylenol. Yeah, you're going to kill yourself, except it's not going to be today or tomorrow. It's going to be in 3 months when your liver is shot and you didn't get a transplant. Side effects, it's very well tolerated. There are very few side effects in large doses. Again, hepatotoxic. Alcohol increases the liver toxicity, so acetaminophen and hangover, yeah, probably not the best, but if you're only taking a couple, probably not a big deal. If you're taking tons and tons of it, yeah, you're maybe going to have some problems. General dose is 500 to 1,000 milligrams every 4 to 6 hours. Max of 4 grams in a 24-hour period. PD dose is 10 to 15 milligrams per kilogram every 4 to 6, with a 40 milligram per kilogram max per 24 hours. It's given orally, and it comes tablets, caplets, elixirs, suspensions, suppositories, chewables, lots of different ways. There's now an IV version of it. Ibuprofen, commonly called Motrin. The other Motrin, or shoot, what's the other one commonly? There's another common brand name for it, for ibuprofen. I lost it totally right now. Anyway, it's a non-steroidal anti-inflammatory. It's a fever reducer used for mild to moderate pain, not commonly carried by EMS services as well. It inhibits the inflammatory response by blocking the formation of cyclooxygenase, or COX-2, which is a chemical mediator for some of the prostaglandins. Use, again, mild to moderate pain and fever. It's contraindicated in known allergies to ibuprofen or other NSAIDs. High-dose ibuprofen also can have some gastrointestinal irritation, causes an increase of risk of bleeding. It's very similar to aspirin. It's like aspirin's cousin. Cause some gastric irritation. Don't give with aspirin or other NSAIDs. Increase that risk of bleeding. Dose is generally 200 to 400 milligrams every 6 to 8 hours. PD dose of 5 to 10 milligrams every 6 to 8 hours. It's usually given orally, and it comes in a lot of different oral forms as well. Finally, we talk about nerve agent antidote kits. These usually come with 2 drugs in there. A lot of times this is called the Mark 1 kit. The newer version of this is also called Duodote, where it's an auto-injector that has both of these in there. If you are in a department that is part of a master plan for nerve agent or Homeland Security projects, you're going to probably be very well aware. You may also have these on your ambulance somewhere that you didn't even know. But you'll have your auto-injectors of atropine, which has 2 milligrams of atropine per auto-injector, and pralidoxime, which is often called 2-PAM, 600 milligrams. And it is an antidote for organophosphate agents such as tabun, sarin, and VX. Oddly, you need more than 1 antidote kit. You need usually about 3 antidote kits for many people. You are going to use this on yourself or your partners, your crew, to help them out in case in which you would get tangled up. All right. So, as an AEMT, responsible for not only knowing which medication is indicated, but what it will do, what it's for, when to give it, when not to give it, who the patient is, and you've got to maintain a working knowledge of your medication. I can't emphasize enough, continue to go back and study, and restudy your medications that we've discussed here. Use all your medication references and resources to make sure you have a good, full understanding of these medications.